In this module, we'll examine how economists model the production of health-related goods and services. And while the concepts and terms and models presented in Chapter 4 may seem abstract now, we'll see later how they'll help us understand a wide range of issues in the healthcare sector, from the effects of hospital mergers and acquisitions to the effects of scope of practice regulations for advanced practice nurses. After reading Chapter 4, you should be able to describe the issues involved in choosing the best input combinations to produce a particular healthcare output, identify causes for diminishing marginal returns and healthcare settings, summarize the role that technology has in healthcare production and its effect on cost, apply isocost lines and isoquant curves to evaluate cost minimization in the production of healthcare services and to see what we mean by that. I will go through an application regarding the optimal hiring of nurse practitioners and physicians by clinic to illustrate that further. And then lastly, you should be able to differentiate the issues associated with long-run versus short-run production. First, we're talking about healthcare production. We need to identify the output of the healthcare production process, and a healthcare output can be as simple as a physical exam or as complex as a treatment for cancer. The production process will involve a team of healthcare professionals along with healthcare technology and other inputs. And so the output provided in the healthcare setting is achieved by combining those various inputs. Other than cost, other differences between inputs exist that may cause the output to vary from one producer to the next, and each input combination can produce the desired output, but that output will not be identical, and that explains why we see variation in the quality and quantity of service provision across different providers. As we'll see shortly, each combination of inputs has its advantages and disadvantages. Some combinations of inputs may be cost prohibitive from the individual or insurer's perspective. Another combination might be socially undesirable or inefficient from a time management perspective. In Chapter 4, we discuss input substitution in the healthcare production process, and this refers to the replacement of one input of production with another input. So a substitution of a medical professional may be done by replacing the person with another professional who's trained, qualified, or capable of performing the same task. Now, for instance, we might see the substitution of a dentist's time with a dental hygienist and a dental production setting. But sometimes substitution of a medical input is not possible. For instance, because of specialized training, a dentist might be the only provider capable of performing oral exams, and so some tasks might not be substitutable in the production process. As we saw in the previous chapter, the law of diminishing returns refers to the idea that as inputs to production are used in higher quantities, their effect on output decreases, and that changes in output resulting from adding one more unit of input, which is called the marginal product of the input. As an example, let's consider a clinic that is seeking to hire a number of assistants. We'll have the number of assistants on the left going from 0 to 7. And then we'll have the total product, or the number of patients seen in total by the clinic, depending on the number of assistants that have been hired. So if you don't have any assistants, you might not be able to see any patients, but that first assistant will allow you to see at least 4 patients. Having 2 assistants will allow you to see 12 patients, and so on. So the marginal product is the change in total product associated with an additional assistant being hired. Going from 0 to 1 assistant, we have a marginal product of 4, going from 1 to 2 assistants with a marginal product of 8 patients being seen, and going from 2 to 3 assistants, we have a marginal product of 15 patients being seen. Then on the far right column, we have the average product, which tells us the number of patients per assistant being seen by this clinic. Here you can see that the marginal product starts to rise with the number of assistants, but then starts to decline once we reach that point where diminishing marginal returns to the number of assistants for this clinic. For example, as we go from hiring 5 to 6 assistants, the number of patients seen only rises from 40 to 42, as the marginal product of the 6th assistant is only 2 patients. And then hiring an additional assistant beyond the 6th actually won't increase the number of patients seen. And so that point of marginal product is essentially 0. Now, why might this occur in different healthcare settings? Diminishing returns and production occur for a few reasons. One is that increases in factors of production, such as labor, may not bring efficiency when other inputs, such as capital, are also not increased. If you only have a few rooms in which to see patients, for instance, hiring additional physicians or physician assistants will not allow for an increase in the number of patients to be seen because of that fundamental capacity constraint. Resources used in producing one type of good or service may not be as efficient or productive when transferred to the production of another good or service as well. And so this may be the case. The marginal product of such resources may be high or low depending on where the resources are employed. And in some cases, they might have a relatively low marginal product and hence diminishing returns. Now, let's take a look at some fundamental concepts and terms related to the healthcare production process. Total revenue is price times the quantity of output sold, or in a healthcare setting, the quantity of patients seen. So you might have Q patients seen by a clinic per day, and the clinic might receive the reimbursement rate of P per patient, and that would bring in a total revenue per day of P times Q. So then profit is the difference between total revenue and total cost, or money coming in and money going out. And in this equation, it's TR minus TC, total revenue minus total cost. So we know that technology is used in all areas of healthcare services, and medical technology specifically refers to the procedures, equipment, and processes by which healthcare providers diagnose, treat, and monitor health conditions, whether that's through improvements in telehealth or advanced healthcare provision in a hospital setting. And we know that medical technology can have a ripple effect on the processes, cost, and output throughout a healthcare organization. And that's something we'll seek to model here shortly. In general, there are two basic motivations driving a healthcare organization adoption of technology, and that can be profit increasing revenue relative to cost. We're also improving patient well-being and the quality of care that's being delivered. From a financial perspective, adoption tends to occur when the present value of future profits attributed to the innovation is above a threshold that's financially workable for the company or organization. And regarding that term, present value, suppose that a hospital plans to receive $10,500 next year. The present value of that amount right now is less than $10,500. Let's say it's $10,000. So the hospital could invest $10,000 now at a 5% interest rate and receive a future sum of money that is equal to $10,500. And so in essence, we're talking about present value. We're discounting money that will be received in the future because we could use that money now, invest it, and receive the same amount in the future. So one main objective of managed care is to deliver quality care at a reduced cost. And that may mean the decreased use of expensive technology, say in specialty care, or through advanced imaging that has minimal or questionable benefit. And so in some cases, technology might be cost increasing, but not really quality enhancing. And that kind of is the role of managed care to manage that balance. So total profit can grow when prices increase, when quantity increases, or when total costs decrease. Whether we have an increase in TR or total revenue or a decrease in TC, total cost, we can assume that prices and quantity cannot change. Then holding down cost is the only avenue by which profits will increase. When thinking about the cost structure facing a clinic, for instance, fixed costs are not changing when the amount of output produced is changing. And these fixed costs may include mortgages or leases, which are constant and essentially fixed. Interest on debt and fixed employee contracts, say from managers and chief executive officers, would also be a fixed cost. Variable costs, on the other hand, do change when the amount of output produced changes. So variable costs include things like labor costs and supplies such as bandages and syringes. So the total cost for a hospital or a clinic is simply the sum of fixed costs or costs that are not changing with the level of output and variable costs, which do change with the level of output. So we can take that total cost and divide it by the quantity of services provided to get the average total cost. The average total cost, or average AC for short, is simply the total cost of producing a given quantity of output divided by the quantity of output. In other words, this is the cost per unit, or the cost per patient seen, total cost divided by Q. Consider the following example. Suppose that La Colombe, a Philadelphia-based coffee roaster, produced and sold 10 million bags of coffee last year. Further, suppose the company incurred fixed costs of $15 million, say for their office space or their cafes, and variable costs of $45 million for the sourcing of coffee beans, roasting, and packaging during the same time. At that level of output, what is the firm's average cost? Given that we have fixed costs at $15 million, $45 million of variable costs, and we have a production level of 10 million bags. In this case, that would be an average cost or cost per bag of $6. Recall the total cost is the sum of fixed costs plus variable costs. If fixed costs were 15 and variable costs were 45, the total cost of production for that 10 million bags of coffee was $60 million. And so if we take that level of output and we take that total cost incurred, then the average cost or cost per unit at that level of output was $6 if the company is selling each bag for $10. They make essentially a $4 profit on every bag, or $40 million in total profit. So total revenue would be, in this case, $100 million. Total cost would be $60 million. And so the difference between total revenue and total cost for profit would be $40 million. We should also note the following for later. Recall that average cost, or the cost per unit, is simply total cost divided by the quantity of output or the number of patients seen. And since total cost is equal to fixed costs plus variable costs, we can use that in the formula to note that average cost is also equal to average fixed costs, or fixed cost divided by Q, plus average variability cost, or the total variable cost of production divided by Q. So just keep that in mind for later, because it will be useful when we talk about profit maximization or cost maximization for clinic or hospital. Variable cost and fixed costs are evaluated within the context of time, the short run and the long run. And the idea here is that in the short run, the cost of at least one input of production is fixed. So you can't build a much larger hospital or a cancer institute immediately. In the short run, you have some fixed costs, but in the long run, all costs are variable costs because all inputs to production are also variable. So you can scale up or even scale down a clinic, acquire new or more innovative equipment, or also hire new managers or healthcare professionals. And in the long run, a producer can make bigger production decisions, say building a cancer treatment center or institute, or adopting new medical equipment. As production increases, the fixed costs are spread over a higher number of output units. And in that sense, the average fixed cost is going to be declining with the number of patients served. For instance, we have output units Q shown here, and we have a given total fixed cost. We can see that the average fixed cost, or total fixed cost, divided by Q is going to be falling with the number of output units. We should note that additional, that is marginal input, is increasing more productive in the short run up to a certain point. But at some point, the law of diminishing returns kicks in and additional inputs become less productive. And that could be because more fixed inputs are needed for the variable inputs to be productive. You might need more space to see more patients, for instance. So if we go back to the previous table in Chapter 4, we see that the marginal product is rising up to a point, but then the law of diminishing returns starts to kick in and it begins to fall. Now, marginal cost refers to the change in total cost. That is the additional cost from producing one more unit of output, or in this case, seeing one more patient. So that is the change, or the delta symbol here, in total cost divided by the change in quantity. And since fixed costs are not changing with the level of output, they are fixed after all. This is also equal to the change in variable costs given for a change in output. And so here we see that marginal cost is really driven by changes in variable costs. For this, fixed costs are not changing. To see this numerically, I consider using the following table from Chapter 4. Here we have the output units on the far left, and then fixed cost, variable cost, the sum of which gives us the total cost of production. Average cost is just that total cost divided by Q. So when producing 200 units or seeing 200 patients, the total cost is $63,000, and the average cost, or cost per patient, is $318. The marginal cost is the change in total cost given a change in output. And so as we go from 0 to 20 units, we see that the marginal cost, or the change in total cost given that change in output, the change in total cost is $400. the change in the number of output units is 20. And so the marginal cost going from 0 to 20 would be $20. That marginal cost is falling, but then begins to rise at some point as the clinic or hospital reaches a certain capacity constraint and the law of diminishing returns to the variable inputs kicks in. Here you can see that the average cost per unit or per patient seen is falling with the number of units produced or the number of patients seen. And as we tend to see these falling average costs as the number of patients being seen is increasing up to a certain point. So firms or organizations more broadly can make major changes in this scale and scope of production in the long run. And economies of So firms or organizations more broadly can make major changes in this scale and scope of production in the long run. In economics, scale is a synonym for size. So we're talking about scaling up operations. Usually that means acquiring larger production facilities, larger plant, or building a bigger hospital, for instance. Often when firms grow in size, they experience a decrease in the long run average total cost as they're dividing out those large upfront or fixed costs across the number of patients seen or across the number of units produced. However, in some cases, as firms are growing in size, they might actually experience an increase in long-run average total cost, as I'll show you in just a moment. But this relationship between the scale of production and declining average total cost is called economies of scale, and this is perhaps one of the more important concepts in economics. To give you a concrete example of this, a paper of choice for many economists is the Financial Times. And when you think about the number of journalists and correspondents and data analysts they have all over the world and think about their total budget, it's got to be in the millions of dollars. And so in essence, they're incurring millions of dollars in expense to bring that newspaper to a subscriber. And if they only have one subscriber, the average cost of production is going to be in the millions of dollars. However, as they increase the number of subscribers and they increase the number of issues printed or distributed, that quantity of output rises and they're able to divide out all of those major fixed costs across their number of subscribers and therefore reduce the average cost of that newspaper. So if they incur an average cost per subscriber of 25 cents and they charge $2 or $3 per issue, they start to make a bit of money through those economies of scale in production and distribution. Now, economies of scope, on the other hand, occur when two or more goods are produced jointly rather than separately, and thus total costs are reduced. So there you might see some cost savings when it comes to healthcare administration, for instance. If you have one set of administrators for a variety of services rather than having two sets of administrators for different services, and economies of scope are possible only for firms and organizations that offer multiple products. In the long run, firms or organizations have the flexibility to make input choices that result in declining average total cost. When a long-run average total cost is declining, the firm once again is experiencing economies of scale. However, at some point, the firm or organization might become too big and its resources, including labor and capital, might become less productive and average costs might start to rise. Now consider the following model. Here we have 5 different hospitals ranked by their size, with a small hospital on the left and an ultra-large hospital on the right. We should note first that a larger hospital will have larger fixed costs associated with the size of the hospital and the equipment that has to be purchased, the electronic health record contract that must be signed, and so on. For a small hospital, you're going to have smaller fixed costs, but when you divide out the total cost of service provision across the number of patients seen, you might find that the average cost is fairly high, and it may be higher than that of a medium-sized hospital or even a large hospital. Scaling up operations, that is, going from a small hospital to a large hospital by expanding capacity or by acquiring new equipment and so on, might actually reduce the average cost of service provision in the long run. And that process, as shown here, we're seeing that by scaling up, you do achieve those economies of scale. However, moving from a large hospital to an ultra-large hospital, one might see some diminishing returns to capital and labor, and you might also start to observe reductions in productivity. That process is shown here and is referred to as economies of scale. When the average cost of service provision actually rises as you're scaling up your operations, maybe it just becomes much more difficult to manage such a large hospital relative to this mid-tier large hospital. So again, in this model, each short-run average cost for short curve represents a specific level of fixed cost, and the long-run average cost curve shows the least expensive average cost curve for any level of output. If you want to see Q3 patients per year, a large hospital would be the least costly way to do that. If you only want to see Q2 patients per year, a medium-sized hospital would actually be the least costly way to do that on average. So in essence, economies of scale refers to a falling cost per unit, where patients seen at constant returns to scale refers to constant cost per unit, and diseconomies of scale refers to a rising cost per unit. I know that some of the concepts we've reviewed in this presentation may be somewhat vague. So here's a nice breakdown of some of the concepts we've covered regarding revenue, cost, and profit. You might find this cheat sheet useful later in the course as we talk about hospital mergers and acquisitions, for instance, or shortly when we start talking about substitution possibilities in the healthcare production process. And here ends the presentation for Chapter 4, Part 1.